institution.
Thanks, Mike. I'd also like to thank John and the rest of the IOM staff that is involved in the National Cancer Policy Forum. This is an extremely important effort for bringing together science and policy. And as you'll see in my remarks, and I think everybody else in the session, there's an awful lot to talk about right now. I want to cover two main areas of healthcare reform. One is the changes in coverage that are happening right now as we're meeting. And the second is the changes in financing and delivery that are all together. These changes are intended to lead to better access to innovative care for patients with cancer as well as all other Americans. As you might guess, it's a challenging process along the way. But to just set the stage, just three big issues that are getting a lot of attention in Congress and in Washington right now. First is, as you know, we just came out of a government shutdown and a big fight over the federal debt limit. That's been postponed only for a few months. The core problem here is, on the one hand, rising spending on the federal side, and same thing goes at the state level as well. State governments are facing some of these same kinds of political and policy challenges, due primarily to increased spending related to healthcare programs. So the aging of the population, Social Security is contributing as well, but the bulk of the pressures that we're facing at the federal level are coming from the Medicare, Medicaid, and ACA related healthcare entitlements. They have what we're seeing now in sequestration, what's happened over the last few years, is in my view just kind of an extension of what's been happening over the last 30 or 40 years as these programs have steadily grown in importance. It's something that members of Congress and the President clearly are taking from their constituents as a national priority to continue Medicare and Medicaid and the like, but the result has been squeezing down everything else that the federal government spends money on, including infrastructure, research and development, early childhood education, a lot of things that influence health over the long term. And what we're seeing sort of repeatedly now is bumping up against the core philosophical differences about how to deal with this problem. There's been talk from time to time about a grand bargain that could resolve it, some substantial changes in our healthcare entitlement programs to make them more sustainable, maybe to help them spend the money better. At the same time, maybe an agreement on some portion of additional revenues to deal with these increased costs. I think the general expectation here is we're not going to get that kind of grand bargain anytime soon, so expect these same kinds of repeat battles to keep happening, just like they have been over the past few years. But maybe a small bargain, something like, instead of just continuing this across-the-board sequestration, again, sort of building in, squeezing down every other program besides the entitlement programs a lot in order to sustain the increasing costs of the healthcare entitlements. Maybe some limited entitlement reform, maybe something that affects federal revenues. Stay tuned. That's going to be probably not a December issue, but January or February. And obviously the other big thing going on now is the actual implementation of the core coverage features of the Affordable Care Act. That's been a bumpy process, but it is moving forward. And I think the main thing to emphasize here is, a lot of people ask me about, well, you were there for Medicare Part D implementation, which is kind of, had some similarities, and it's an exchange program, lots of competing plans, new programs people had to adapt to. I think one difference here, aside from the bigger role of states, is that this is going to take at least a few years to sort out. So with the Medicare Part D expansion, just like Medicare in 1965, it was a nationally relatively consistent approach that was pretty much done at the end of the first open enrollment period. There were some startup issues and so forth, but the program was pretty well established with the vast majority of people in it by the end of the first year. That is not going to happen here. This is going to be a multi-year process on both the Medicaid side and on how the exchanges and the coverage in them sort out. And we're just now starting to work through that. So on the Medicaid side, this is one you haven't heard about in the news very much because things seem to be going pretty smoothly. For the states that did expand coverage, there are already hundreds of thousands of new enrollees reported. Obviously not all states have done it, but this too has a historical precedent when Medicaid started, when the Children's Health Insurance plan started in the 1990s. About half the states took it up right away. Then there was a tail out on the right side lasting 4 or 5 in the case of initial Medicaid, 16 years before all the states took it up. The medium colored states here are ones that are considering expansions along the lines of what Arkansas was recently approved to do, sort of competing private health insurance plans in something like an exchange where you get a voucher to choose among them if you're a beneficiary. And we already know a lot about how Medicaid coverage works and what the challenges are. So this is fairly well understood territory. This is a state, this chart showing state differences in the exchange implementation. So the ones that are relying on the federal exchange versus doing it themselves. Obviously, there's a lot of overlap between these two charts. And here, obviously, there's been some challenges in initial enrollment due to the challenges with the website and the electronic systems that support people finding out about what their coverage options are and then enrolling in a plan. The administration says they're on track to largely fix those problems by the end of November. I can tell you from my experiences with implementation that those won't be the end of the line. So even if these initial issues about getting information on a plan and choosing and enrolling in one get resolved, there's still a second set of kind of electronic and systems issues about connecting your desire to enroll in coverage with the actual coverage that's available for use. So a lot of people have pointed out that Part D had some real implementation challenges at the beginning too and got through them. The difference was that those implementation challenges weren't the ones that we're facing now. The Part D website got up a little bit ahead of the start, and there were some glitches in it with wrong drug prices in there for some beneficiaries and wrong subsidy calculations that had to be worked through. But the real problem was when coverage started in January and people showing up at pharmacies and in some cases not having up-to-date information on their plans right there available so they could connect with their coverage. That may be an easier problem this time around because the December enrollment period ends in mid-December and not December 31st like in Part D, and there are going to be fewer people who are going to be starting coverage on January 1st. On Part D, there are more than 10 million Medicare beneficiaries, including all dual eligibles who switched over on one day, but there still are going to be some issues ahead. And there's a third set of problems that we haven't really worked through yet, which is are people going to find the coverage available worth enrolling? And I'll come back to that at the end, or maybe we can in the discussion if we have time. I want to turn to the other pillar of healthcare reform issues right now, which is payment and financing reform connected to delivery. The ACA and other reforms happening at the state level and the private sector, you're going to hear a lot more about from other people on this panel, are doing things in kind of a different way from the traditional way of saving money, which is just squeezing down prices to providers and instead focusing on ways to reform care itself. So true delivery system reform supported by paying for what we really want, not just volume and intensity of services, but better results at a lower overall cost. There are a lot of things that happen in care today, especially for cancer patients in terms of developing plans and making sure that patients are supportive of them and those plans are being followed, that they're based on the latest evidence, coordinating care, being available to head off complications and so forth that get very little or no support in traditional healthcare reimbursement systems. And the point of these reforms is to change that. Don't worry about the details on this chart. Just I'm going to say 2 points. First point is that if you look at oncology care in particular, I think some of the most important changes in provider payment reform are actually being led in cancer care. I'm going to talk about a few examples of those very briefly in a minute. So this is a place to look for what could be a model for reforms in payments that would affect other parts of our healthcare system, other specialties, other types of care, and the like. I think 2 key dimensions to think about are when you're moving away from fee-for-service payments, just paying for volume and intensity, there's sort of 2 ways to do it. One is to shift the way that oncologists and other individual providers involved in cancer care are paid, so moving towards more of a case or person-based payment. That's what I mean by transition to person-centered payment here, where the payment is tied to things like reporting on or improving in measures of quality or performance. The other way to do it is to promote coordination by paying multiple providers together. So think about a bundled or episode payment that would include not just the oncologist, but maybe to some extent the primary care providers involved in screening populations for cancer, the surgeons involved in performing surgery, so that the overall team is working together better. That's the vertical axis on this chart. We are now doing a review of a lot of the activities underway in payment reform in conjunction with a project for the Centers for Medicare and Medicaid Innovation. Like I said, what we're finding is a lot of activity related to cancer. Broadly speaking, 4 categories to mention. One is clinical pathways. This is moving towards payment based on using well-developed guidelines based on clinical evidence and expert opinion for cancer care. So this might affect chemotherapy choices, follow-up imaging choices, things like that. Typically, when these programs are implemented so far, they've involved an additional payment to the coordinating oncology group for adhering to these pathways most of the time. What's most of the time? 80% or so, not 100% of the time. What we're hearing talked about is maybe limiting payments in cases where a lot of the care is off pathway. So the providers in that case being more at financial risk, not just kind of a bonus for following the clinical pathways. Patient-centered oncology medical home is an additional payment to the oncology practice for basically setting up the kinds of features that have been made famous in primary care medical homes for making sure that patients are actually getting the care that they want, that it's well coordinated, that it's supported by various structural features, IT systems and the like in a practice. It involves an additional payment and maybe some upfront setup costs for transitioning a practice in this direction. What we've seen outside of oncology, I think maybe starting to happen in some of the oncology medical homes as well, is transitioning from just an additional upfront payment to get this system in place and to use it for your patients to a component where the oncologist gets a piece of shared savings reimbursements. If overall costs come down, if quality goes up, then more of their payments are tied to that over time. Bundled payment is a further step in that direction, where instead of basically replacing some of the fee-for-service components with an overall case-based payment, a lot of people think of bundled payments as being just a flat, fixed amount that you get for like the all care over, say, a 3-month or 6-month period, over initial period of or episode for cancer treatment. It doesn't have to be that way. Just about all the implementations that we see so far are doing that piecewise. I think you might hear a little bit more from Lee about some of the things that they're doing on taking out what were fee-for-service payments, say, for chemo administration, converting it to a per patient amount that works for the practice, but is no longer tied to volume and intensity, and instead it is tied to some of the kinds of dimensions of quality or performance that I've already talked about. A further step in that direction potentially is an oncology accountable care organization where the payments are tied more completely to the quality of care and the overall cost of care for a patient. So it's moving even further in that direction, away from fee-for-service based payments to a case-based payment that encompasses a lot of care and a lot of providers. My point, I'm going to skip over all of that and just kind of emphasize that this is a very live issue right now. Congress, who says there's no bipartisanship in healthcare anymore? The Ways and Means Committee, the Finance Committee, on a bipartisan basis, just introduced a reform for physician payment in Medicare that is very consistent with the kinds of reforms that I just described, that would repeal the SGR, would give providers a chance, physicians a chance to continue in fee-for-service, but at a pretty low rate, so 0 updates for the next decade, and with some strong incentives to move towards those kinds of more case-based payment approaches that I was just describing. Doing all this, I want to emphasize, requires a very strong, or it's certainly supported by a stronger evidence infrastructure, both on the quality of care that's being provided and in terms of providing data to the patients and physicians and other providers involved in delivering care, so they can find ways to improve on performance and understand where they are and view this not as just a big, uncertain kind of financial risk. Remember that providers deal with risk every day in their practice, and you can't practice oncology today without spending a lot of time on things that you don't get reimbursed for at all, like extra time with a patient when they need it, answering emails, phone calls, things like that. The difference is that that's pretty well understood today, so you can factor it into your practice planning. We're not there yet for these kinds of reforms in care delivery, and data are absolutely essential to make that happen. I would just emphasize that it's probably going to be coming from the main emphasis for getting to those better data and evidence systems is going to come from moving forward with these kinds of reforms in provider payment. I should say that there are similar kinds of reforms that you can envision on the consumer side. So financial incentives for consumers, for patients to use practices that are following best evidence-based care. Those are coming in value-based insurance design and a lot of other tools, non-financial tools, to help encourage more effective use of care. Again, all supported by better evidence. One final quick point, sorry for going over, that should be a big concern for everyone concerned about the quality of cancer care in the new exchanges and under these systems is addressing the problem of adverse selection. You really need broad participation in these programs, in these kinds of insurance pools and the like, for them to remain stable over time. There is a penalty that you pay if you don't enroll in coverage. It's very small. There's a lot of political pressure that I think is just going to grow to at least delay that penalty. So something to think about from a cancer policy standpoint is, are there better ways to keep these insurance markets stable? Otherwise, you're going to put an awful lot of pressure on things like coverage requirements and the like that may be very difficult to sustain otherwise. So thank you all for the opportunity to cover a good bit of territory on healthcare reform. I look forward to the rest of this discussion and the further work of the Cancer Policy Board. Thank you.
Mark, thanks very much. Mark is going to have to leave early, so we are going to take some time for questions for Mark, if there are questions. You know, one coming.
Thank you. Doug Peterson from University of Connecticut Health Center. And I'm coming, Mark, from the perspective of dental medicine. I'm in the School of Dental Medicine at UConn, and I'm also co-chair of our head and neck oral oncology program in the Health Center. And I'm also a new appointee to ASCO's Supportive Care Guideline Advisory Group. My question is really around, as we advance the science from the lab to patient care, and as we advance the pathways coming from guidelines, to me that's almost the easy part, because now personally I'm interested in linking those advances with policy change for access and reimbursement. In the case of dental medicine, we're typically viewed as non-medical, even though we're often providing medically necessary cancer care. And I've noticed in the briefing book that others have contributed on nutrition and other aspects of access to care and disparities. So my question is, you mentioned more data, and as we build pathways around guidelines, what additional kind of policy-centered data will change the model so that there's cancer care reimbursement, some of which will cost more than we're doing now, some of it will save millions of dollars if we follow these pathways?
Yeah, it's a really good question. I think your own background and things you're involved in highlights how important it is to bring together not only the data, but the care delivery systems in a holistic way to meet the needs of each cancer patient. I do think these payment reforms that I just described are the best way to get there. Given all the pressures on costs that I mentioned at the outset, it is very hard to add in additional specific categories of payment for things that don't exist today into a fee-for-service system that does not provide very good incentives or support for either getting the data that you need to take care of a patient or identifying and then acting on the key opportunities for quality improvement. That said, a lot of the financial incentives are in the direction of making these changes in ways that reduce costs. So not going to the third or fourth or fifth line chemotherapy agent that's really expensive and doesn't lead to improvements in outcomes. Avoiding the preventable hospitalizations and complications and readmissions complicating surgery. There are going to be a lot of treatments coming along that will be more expensive for for particular kinds of patients, and I think the evidence thresholds for those is going up. I think Lee's going to talk a bit about some of those issues later. There are ways, I didn't really have time to talk about them, to think about changes in reimbursement for these complex and costly technologies to bring them into the same direction of focusing on results for patients. I mean, why should we be paying for drugs and other treatments on a fee-for-service basis if we're trying to move the entire system away from that and towards more patient-level evidence? So coverage with evidence development has a lot of promise, I think, in the area of these new reimbursement models, especially if it can be coupled with easier ways of generating evidence from people participating in getting these kinds of treatments, and reimbursement models that are tied to, in some sense, results for patients. Actually getting better outcomes, I think, is something else that should be coming too. None of these are easy steps to take, and I think it goes back to that last point I was trying to make about the problem of adverse selection. If you put a lot of pressure on health plans just to get costs down, they're going to do a better job of that, and that highlights the importance of having relevant evidence that if we are, if we are developing new treatments that are extending lives and improving lives that are worth spending potentially a lot more money on, there's going to need to be better. Those are going to be supported better if there's better evidence that they actually have an impact in practice.
Thanks, Mark. So one more question.
Yeah, thank you. Nicole Stout, Cancer Rehabilitation Consultants. You speak to the overall cost of care when you're talking about bundled payment. And from looking at your chart, you're talking about the cost of disease treatment with some prevention screening thrown in, I guess, as a cost measure. However, we know the cost of morbidity associated with disease treatment is expensive. It's significant, and it extends quite a period of time after treatment is completed. Do you see that as a part of a bundled payment plan? I mean, you just spoke to the gentleman in your response about outcomes, and if we're measuring outcomes based on function and morbidity, that would need to extend well beyond disease treatment completion. And how would you anticipate that encompassed in a bundled payment plan, and over what period of time are we talking about cost of care?
Well, remember, these are supposed to be payment reforms that are about value, not just about cost. And so going into the payment incentives should be considerations both of efficiency gains, a way of getting the same results at a lower cost, plus outcome improvements, including downstream improvements in morbidity and mortality. One of the ways to get at that in payment systems is to have early markers, things that you can observe today that are strong predictors of those longer-term outcome improvements. Outside of cancer, these are things like, say, hemoglobin A1C levels in people with uncomplicated diabetes, or blood pressure in patients with hypertension, or cholesterol levels in patients with coronary artery disease. We don't have as good of markers for many types of cancers as we'd like, but this is an area where I think there should be an even stronger link between what's going on in the payment and reimbursement side and what's going on in the evidence development side, with validation of biomarkers and more confidence that the treatments that we're using in particular patients are really leading to improvements in outcomes, and those are worth paying more for.
I would suggest there's also an evidence base that supports markers of function that could be tracked during and after treatment as well.
Absolutely, absolutely.
Thank you.
Thanks, Mark. Thanks
Right,
very,
thank
very
you all.
much. We'll move on. Appreciate your comments. So we'll move on to our next talk from Diana Boost, who'll talk about comparative effectiveness research in cancer. Diana?